nós teremos agora o primeiro painel, que tem como tema o modelo canadense de atenção à saúde. Gostaria de convidar ao palco para coordenar este painel o senhor Aderval, Filho, presidente do Conselho Deliberativo da Unidas. Por favor, ocupe o seu lugar, que receberá a painelista, doutora Katherine Rouleau. Convidamos também o debatedor, doutor Eugenio Vilaça Mendes. Neste primeiro painel, então, teremos como coordenador Aderval Filho, que já está aqui no palco, teremos como painelista a doutora Katherine e teremos como debatedor o doutor Eugenio Vilaça Mendes, que também ocupará o seu lugar aqui na mesa. Inicialmente teremos a apresentação da Katherine, logo em seguida também uma breve apresentação do doutor Eugenio e haverá tempo para perguntas. Nós informamos que as perguntas deverão ser feitas por escrito, utilizando o formulário que está na apostila do evento. Na apostila, vocês têm alguns materiais, eu peço que, por favor, observem, verifiquem o material que vocês receberam do evento. Então, desde já, prestando atenção aqui na apresentação, vocês poderão formular perguntas e essas perguntas devem ser entregues às recepcionistas da sala. Como nós estamos com um grande número de participantes, por favor, façam um sinal, levantem a mão, para que a recepcionista possa visualizar, então, que vocês querem entregar alguma pergunta aqui para os participantes do nosso primeiro painel. Então, passo a palavra agora ao coordenador da mesa, senhor Aderval Filho. Por favor, um bom trabalho.
Obrigado. Bom dia a todos. É com muita satisfação que abrimos aí esse segundo Congresso de caráter internacional da Unidas e o 15º Congresso que a gente vem realizando todos os anos. E nesse nosso painel agora, que é o Modelo Canadense de Atenção à Saúde, nós convidamos a doutora Katherine Rouleau para fazer a sua apresentação. A senhora terá 45 minutos para fazer a apresentação, ok?
Bom dia, muito obrigada a Unidas pela invitação. I'm very sorry that I do not speak Portuguese. I will try to speak slowly in English. And I will start by saying that I know that everybody in this room has spent quite a bit of time over the last year in activities that were meant to keep people and populations healthier. And I have to tell you that to take a Canadian out of gray, wet, cold Toronto in December to bring her to this little piece of paradise is probably the most impactful health promoting activity you've all been involved in this year, and I am very grateful for the invitation. Thank you. So I don't have any conflict of interest. This first slide is actually to remind myself to acknowledge my Canadian colleagues who have provided some of the material that I will be presenting today. I am not an expert in healthcare policy. I am actually a family physician. I work in the city of Toronto, and I will be speaking from the perspective of a practicing physician in Canada. I will speak quite a bit about our Canadian healthcare system, which is a single-payer system. But I do want to acknowledge that this is neither the best nor the only model of healthcare, and I wouldn't want people to assume that this is what I am here to do. But I will express some of the views of many Canadians with respect to our healthcare system. This is a picture of a character we call Bonhomme Carnaval. I will try as much as I can to link the Canadian reality to the Brazilian reality, and I will highlight what you do better than us. I think to have a carnival in the heat on the beach wearing bathing suit is a definite advantage to our version of carnival, which happens in February in snow surrounded by ice. Nonetheless, we've learned a few things from you, and this is our version of carnival. This is the world with little red stars indicating where some of the speakers are over the next few days. Canada is the big green mass at the top, and you will recognize Brazil. And this is Canada. This slide is here to remind me to tell you that there are, in fact, in Canada, 13 healthcare systems, because healthcare is actually a provincial matter in our country, and the healthcare systems are managed by provincial governments, a little bit like in your country. And so I will speak about the Canadian healthcare system, and more specifically about the Ontario healthcare system, which is where I work. This is a picture of Toronto, where I live and work, and there you go. So this is the outline of what I will talk about today. We'll talk about the evolution of Medicare, which is the name we give our healthcare system. We'll talk a little bit about the private-public responsibilities, about the overall performance, and we'll talk a little bit about the future and where we are at in Canada in terms of the crossroads. And this is the picture everybody knows of Canada. This is Niagara Falls. So let's turn to the first part of our talk, which is the evolution of the Canadian healthcare system. Canada is a large physical country, but a small population country with only 33 million people. We spend about 12% of our GDP on healthcare, and health represents about 34% of our federal budget. We have 66,000 physicians, and almost half of those, in fact, a little bit over half of those are family physicians, and I'll tell you a little bit more about that later in the presentation. This is actually a key piece of our healthcare system. The federal government in Canada actually sets the principles. We have laws regulating healthcare in Canada, but it really is there to set the tone and some of the parameters around financing. The actual nitty-gritty and the decision of what actually is paid for within the public sector envelope is determined by each provinces. You shouldn't even look at this slide. This is just there to remind me of some of the big dates. I was asked to comment or give you a little bit of history on the Canadian healthcare system. Our healthcare system, the way we know it now, actually took shape in the mid-1940s after the war in the province of Saskatchewan, which is at the very middle of the country. And there was a law passed to allow unions to actually raise funds to pay for hospitals and allow the hospitals to provide free or publicly funded care to union members. That evolved on the political scene such that by the 1960s, the federal government had agreements with almost every province in Canada to share the cost of hospital-based services in a 50-50 sharing of the cost. When Saskatchewan finally got money from the federal government to pay for some of those hospital-based services, they decided to use some of the money they were now saving to pay physician services out of hospital. And so you can see that even at its inception, our healthcare system was not globally considered. It started out with paying publicly for hospital services, then it included physician out-of-hospital services. But that's essentially where it stopped. And to this day, we live with the consequences, both good and bad, of that decision. Over the course of the next decade, all the provinces developed agreements to have 50-50 cost sharing with the federal government, both for hospital services and physician services. And those were actually englobed under the 5 principles of the Canada Health Act, which I will show you in a minute. But in many provinces, physicians started charging extra privately for some of their services. So a patient would show up for services to see their physician, they would show their health card, and some physicians were saying, well, in fact, for this service, we'd like you to pay some extra money. In 1984, the federal government put an end to that by changing the law to essentially prohibit what we called extra billing. And this was really rooted in the recognition that this was a vital part to protect access and universality of our healthcare system. Later in the 1990s, the federal government changed a little bit the way it was providing the funding and no longer gave just money, but actually gave tax points. So it allowed the provinces to raise a greater proportion of the taxes, and in fact englobed both health services and education in what could be funded with those tax points. And this was really a way to give the provinces a bit more flexibility and autonomy on how they managed their budgets. And then lastly, or not lastly, but most recently in the early 2000s, in 2003 and 2004, there was a recognition that the system as we know it worked pretty well, but not perfectly, and there was indeed room for improvement. And I'll talk a little bit later about those 2003, 2004 evaluations of our healthcare system, not the least of which was the recognition that we needed healthcare professionals and the healthcare system to be more accountable, to actually demonstrate what we were getting for the money we were spending on healthcare. And lastly, in 2005, there was actually a challenge to the Canada Health Act, this piece of legislation that enshrines a publicly funded single-payer system in our law. And the challenge was from somebody in Quebec who argued that because they had private insurance and could pay for a hip replacement in the private sector, they should be able to jump the queue and get their hip replacement faster. The courts in Quebec acknowledged that there were serious challenges with wait times in Quebec and indeed said that it was okay for private insurance to pay for a procedure if it could not be provided in a timely manner within the public system. That judgment does not apply to the rest of Canada, and how this will really impact the rest of Canadians is actually still being debated. I can tell you that one of the very concrete consequences it's had is that it's propelled us to look at wait times in a particularly critical way, and I'll talk about this later. So here are the 5 principles of the Canada Health Act. When we talk about our healthcare system and what is the essence of the Canadian healthcare system, these are the things that define it. It is publicly administered, it's universal, which means that it applies to every single person in the country. It is accessible, and it was this principle of accessibility that was added in 1984 that was felt to be challenged by the extra billing. It's portable, so you can actually seek healthcare in any province and be reimbursed by your province of origin. And it's comprehensive, which is a bit of a vague term. It is meant to say that it encompasses all key health services, but in fact, you will see that there's a lot of debate about whether this is indeed the case in Canada. So here are the key lessons of this first section. We have 13 healthcare systems in Canada. It is seen, the Canada Health Act and our healthcare system is seen by many Canadians as a pillar of our Canadian identity and is fiercely defended by many. It is significantly rooted in values of equity, solidarity, and collective responsibility. This is where it originated, and this is in fact what has continued to provide support for it. But it does face ongoing challenges. This is a picture of the Chateau Frontenac in Quebec City. So what's private and what's public in Canada? We often Canada is often branded as a totally public healthcare system, but in fact, it really isn't. I know you're all experts in this, but when we speak about public and private, we of course talk about 2 different things. There's the funding model, so who pays for the health services, and those can be public or private. And then there's who delivers the health services, and this can again be public or private. In Canada, we would be in this, most of our healthcare provision is in the square labeled number 3, in that it's mostly publicly financed and privately delivered. Physicians in Canada are not employees of the state, as in some other countries, most notably the UK. Physicians in Canada are seen as small business owners, essentially, and are privately regulated. So we're clinically independent. We bill our services to the government, but we're not employed by the government. We don't have a union, for instance, that defends us. As I mentioned before, there's a ban on extra billing, and physicians have an option to opt in or opt out of the publicly funded healthcare system, but I think we've demonstrated over the years that people within the public healthcare system actually do quite well. And so this is what's covered by public funds. Hospital care, essential physician services, most laboratory tests, and we're starting to curtail those based on evidence. So Prostate-specific antigen, for instance, as a screening method has now been demonstrated not to be an effective test and is no longer covered in Ontario. Most of the screening maneuvers are actually covered, and in fact in Ontario right now, family physicians who cover their populations with these tests actually get a bonus from the Ministry of Health. But there's a big gap. So we don't have any coverage for physiotherapy. Most notably, we have no coverage for medication, and that is a huge issue for us. Certainly, if the goal of the Canadian healthcare system is to keep our populations healthy and productive and engaged, not giving them access to medication is a big, big impediment to this. We have no coverage for dental services, which is also an aberration, no visual care, and no coverage for prosthesis and medical devices. So how does Canada compare to other countries? Again, Canada is often branded as the most publicly funded healthcare system, but in fact, we are not. Only about 70% of healthcare expenditures are public in Canada. The others, the physiotherapy, the dental, the pharmaceutical, accounts for about 30%. And you see here that we do better than some, better than the US and perhaps better than Switzerland, but there are many other countries in the world, some of which you'll hear about later this week, who actually have a more heavily weighed public healthcare system. And again, to reiterate, physician services and hospital services are largely privately funded, but pharmaceuticals and dental care, among others, are not. So here are the key lessons of this second section. Canada does not have the most publicly funded healthcare system in the world, much to the chagrin of some of us who see the impact on individuals and on communities. In some areas such as dental and vision care, Canada lags behind most, and payment for pharmaceuticals is almost entirely borne privately and accounts for a lot of the burden of ill health in our setting. This is a picture of the western part of the country in the Rockies. I was asked to talk about the overall performance, which is a big, a very large area to cover. I can tell you that in those documents that were published in 2003 and 2004 in Canada, there was a lot of talk focused on performance. And those 12 areas are what was recommended to focus on in terms of outcomes. I will not address them all, but I will talk about wait times. I will talk about primary care. I'll talk a little bit about prevention, promotion, and public health. For those of you who are dying to hear more about the Canadian healthcare system, as I'm sure you all are, you can actually look up on the web some of these documents that are produced by the Medical Council of Canada, and they have actually some very interesting interactive tools online that will allow you to search for performance indicators over time and by region and by age. And so if you're interested, this is certainly there for you to consult. In 2011, the report focused on wait times, on pharmaceutical management, on electronic health records, and teletriage and health innovation, 5 areas that were felt to be deficient in the healthcare system. And in 2012, in this report, we focused on home and community care, health human resources, telehealth, access to care in the north, and comparable health indicators. And again, for those of you who are really interested in those, you can certainly see this online. For this presentation, I'm going to focus on the following indicators. We'll talk a little bit about health expenditures as a share of GDP, on health outcomes, access, particularly wait times, because that's a big issue for us in Canada, sustainability, and primary care. So how does Canada do in terms of health expenditure? We spend, as I've mentioned, almost 12% of our GDP on health. And you'll see from this slide that we do better than some and not quite as well as others, but we're generally in the same ballpark as most OECD countries. We also see that our costs are growing, but they're growing at essentially the same rate as everybody except the United States, which is really seeing an exponential increase. And I know that there will be presentations about the United States and their healthcare system over the next few days. And so Canada is doing okay. We could do better, and we certainly have lots to learn from others, but we're not in dire straits. Again, this is a picture of our carnival. You will see that people in our carnival wear a lot more clothing than at your carnival. We try to keep it colorful. We don't do always as good a job as you do. We can build castles in ice, and I suppose that's a big benefit. I also suspect, though this would probably not be politically correct for me to say in my country, that if we were given a choice between a sandy beach and samba versus an ice castle, we would probably pick the sandy beaches. Nonetheless, you're all welcome to come and visit in Quebec City in February. We can lend you some coats and heavy boots. So, I see. I can see there's a lag here. Health outcomes in Canada. So if we look at health outcomes in terms of potential years of life lost, we see that we're doing not badly. We see with cancer, we see it with heart disease. We see, however, that we do better with a public healthcare system than with a private healthcare system, and that's been shown repeatedly in studies. And I will actually, for the sake of time, we'll actually wade through. I do want to talk about wait times a little bit, because that is one of the common criticism of the Canadian healthcare system. So you see here that in a report published in 2006, it was recognized that wait times to see physicians and to get procedures in Canada was way too long compared to others, including Germany and the United States. For some of the proponents of a two-tier healthcare system in Canada, this was taken as a sign that we needed to include more private funding in our healthcare system. But in fact, this slide will show you that heavily publicly funded programs actually do better with wait times than privately funded ones. And this, I apologize, I didn't know this slide was going to do this. So in fact, in our case, we've looked at targets, and we're actually achieving our targets now, or well on our way to doing it. The issue here is that the problem with the wait times is not the publicly funded piece, it's the way we do business. And we've recognized in Canada that we need to address this head on. So these are the 5 priority areas. All of them are actually achieving benchmarks internationally now. We've got some ways to go, but we're doing okay. This is a picture of the rodeo in Calgary. So is this sustainable? There's a current in Canada right now that says that we will not be able to sustain our publicly funded healthcare system. And yet, our expenses have remained essentially the same. One of the reasons people say that this is not sustainable is because of the proportion of healthcare spending with respect to the global spending. But really, what's happening here is not that so much that we're spending more in health, it's that the size of the pie is shrinking. Our revenue in taxes is going down, and so the proportion of healthcare is then increasing. And that is really the question that is posed to Canadians. Is this what we want to spend our money on? And should our government look at its overall taxation plan and funding to make sure that we guarantee access, universal access to healthcare? I'm going to speed through the next few slides because I'd like to talk about primary care, if I could. So first I will show you this, these slides, which show that actually the cost of hospital care and physician costs have actually gone down in Canada over the years. It's really pharmaceuticals and other medical devices that have actually gone down. So it's the privately financed pieces of health expenditures that are going up, not the publicly funded ones. This is the cost of drugs in Canada, and you can imagine what kind of an impact that has on our healthcare expenditures. And so the evidence on sustainability is that while spending is growing in healthcare, it's mostly from the privately funded portion. Pharmaceuticals are by far the biggest driver of this increase in cost. Tax reductions explains why the proportion of healthcare spending is growing so quickly. We are all using more healthcare, and we don't always know whether we're getting more value. And we need to focus on integration across the continuum. This is the Yukon. So what does the future hold in the next 10 minutes? Let me turn to that. Those reports of 2003, 2004 really highlighted primary care as one of the way forwards as well as a quality agenda and a focus on accountability. So primary care needs to be reformed in our country. I apologize, I thought I'd remove, there we go. So family medicine and family health teams in Canada is really the foundation of primary health care. In our country, we focus on, when we mean family medicine, we mean comprehensive, continuous, patient-centered, and community-responsive care. Many of you will know this already. I know there are some international experts on primary care, but for those of you who may not, when we talk about primary care, what we mean in Canada is first contact care, addressing on average 80% of the presenting problems. It is the foundation of any healthcare system, and its benefits include improving access, improving outcomes, and lower costs. So why should we focus so much on primary care? Well, the research has actually shown repeatedly now that strong primary care is associated with better outcomes. You see some of them here. We know that primary care strong countries do better in terms of potential years of life loss. We know that where there are more primary care physicians, people do better, they are healthier. We know that having a strong primary care system protects the population against adverse health outcomes, more so than medical insurance and more so than non-compliance will do. We see here that adults with a primary care physician rather than a specialist as their personal physician have lower cost of care and better outcomes. We see that primary care tempers or lessens the impact of health inequality within a country as well. And this is research that was done largely by Barbara Starfield from Hopkins University and in fact has been borne out around the world repeatedly. So countries with strong primary care have lower overall costs, have generally healthier populations, and within countries